Hills and Valleys is a podcast that uncovers stories from leaders in healthcare, tech, and everything in between. Straight from the heart of Silicon Valley, we give you a look at the good, the bad, and the future, one episode at a time. Brought to you by Potrero Medical. Hi everyone, my name is Omar M. Khatib. I'm the Director of Growth at Potrero Medical, and I'm very delighted and honored to be sitting with Dr. Azra Bihorac. Did I pronounce that correctly?
Yes, it's correct.
Okay, good. I'm happy. And we're coming to you from San Diego, California at the Society of Critical Care Medicine meeting. Dr. Bihorac is a professor of nephrology and medicine at the University of Florida. And I'm going to defer to her to kind of expand a little bit about that on her bio and her background.
Right, so why is nephrologist at Society of Critical Care Medicine? Well, I practice as intensivist. I was trained as a nephrologist, and then at the time when I finished my fellowship, I moved from Turkey, where one of the main modality for treating patients with end-stage renal disease was peritoneal dialysis. When I moved here in 1999, nobody was on peritoneal dialysis. And everybody was on hemodialysis. So I had to switch my research interest, and that's when I became interested in acute kidney injury. And after finishing nephrology fellowship, I felt that as a nephrologist, I can't really understand acute kidney injury because I'm not there when people developed it. So I said, well, I gotta be there if I want to change the disease. And I said, well, I have to be intensivist because that's where the AKI occurs the most. And that's when I decided to do another fellowship in critical care medicine. And when I finished that, I stayed as a faculty in a Department of Anesthesiology because they managed surgical ICU at University of Florida, and I got tenured and promoted there and then eventually transferred to nephrology, but my clinical practice remains in ICU, in intensive care unit. I do a little bit of consulting as nephrologist, but mainly I work as an intensivist. Obviously, I always wear both hats, right? But that's my little background, why am I in ICU and why am I here at FCCM and why do I care about kidneys in ICU?
Yeah, well, so, before, I definitely want to ask about that, but I'm just curious if you can kind of expand on it. So my father happens to be a surgeon as well, and he was a foreign medical student and came into his residency here in the U.S. I think a lot of people don't understand the difficulty and what that takes to do that. Can you expand and share a little about that?
Sure. Well, I finished medical school in 1990 in Sarajevo, University of Sarajevo. I went to med school when Winter Olympic Games were in Sarajevo. It was still Yugoslavia then. And then in 92, the war in Yugoslavia started, first in Croatia and then in Bosnia. And I lived in the northern part of the Bosnia and escaped, thankfully, from my town and as a war refugee went to Turkey. I was intern at that time, graduated med school. So when I went to Turkey, I actually was able to start residency at the Marmara University in Istanbul. And it was really, due to the gracious support from my mentor, who was a nephrologist, Dr. Emela Kolu. She was chairman of medicine and professor of nephrology. And it was a very strong department in medicine and nephrology, and I fell in love with nephrology, obviously. So I finished my medicine there training. It was 4 years in Turkey as opposed to 3 years here in America. And then I started nephrology fellowship, and I got fellowship from International Society of Nephrology to come here and do research. So I moved to Gainesville, studied my research, and then got political asylum because I couldn't go back to Turkey, I couldn't go back to Bosnia. So in order to practice medicine, I had to repeat all of my training. So I first finished nephrology fellowship, and then I went back and did internal medicine again. And then I did critical care medicine. So when I got my first job, I was 40 years old. And I got my first salary. Up to that point, my family basically took care of me. So it's always funny, when people talk about, people who live off others under the quotes. I always remember that. If it wasn't for for my family working and helping me, I would never be who I am. Right? But you never know the circumstances of your life. That's why I think sharing and supporting each other is so important,
Absolutely. And you must be very passionate about what you do because you went through it twice just to get to where you are today. So you mentioned that you developed an interest in acute kidney injury. Now, in medical school and training, there's all kinds of different pathologies in different areas. So what was it about acute kidney injury that got you so interested?
It's interesting because the first, when this is all the coincidences of the life, the town I was born in, right? It's on the northern part of Bosnia, on the river Sava that goes to the Danube. And that's part that is known for a disease called Balkan nephropathy. It's endemic kidney disease there. Because of, later it turns out because it's a fungus, it's in the ground, in the water. And people will just develop shrinking kidneys. So there was a disproportionate amount of people with end-stage renal disease, a lot of dialysis patients where I was born. And, as a medical student, we were doing field work to understand Balkan nephropathy. So it's really true. A lot of people think it's like, oh, you really lived there? Yeah, I did. And then, before the war started in my town, a lot of doctors left. But I just started my job, so I have to stay because otherwise I would lose the job that I just got. So they made me director of dialysis, although I didn't know nothing. So, okay. And then with my professor in nephrology was very strong in Marmara University. She was very famous. There was a lot of research in peritoneal dialysis and in glomerulonephritis. It was a referral center for rare kidney diseases. And so I saw a lot of things. When I came here, acute kidney injury became so apparently important because every consult we would have was an acute kidney injury. And in 2004, and I still remember that, the first consensus guidelines came out on AKI. And up to that point, only people who ended up having dialysis, the most severe stage of AKI, complete failure, would consider having acute renal failure. So if you consider only them, it's only 2%. But when they published rifle criteria, Dr. Callum and Ronco, 2000, Beloma, I still remember that paper. I was fascinated because suddenly you understood that there is a whole spectrum, right? And from mild to moderate to severe. And I was taken by that paper and wanted to understand in our own data how big is the problem, right? And that's kind of also another interesting story. So, it was obvious that, and I look at the data and we understood that short-term outcome, it's a prevalent, the short outcomes are, bad. And we did one of the papers on that. That was one of my first publications. But then I became interested in long-term outcomes. Like, in other words, we were thinking, well, it's not just that you end up developing this acute kidney dysfunction that affect your outcome in hospital. But perhaps even when you leave, it may affect your outcome. We hypothesized. And at that time, nobody believed in that. Nobody. This is long ago, 2007. And I finished nephrology. I was doing internal medicine. And my current boss, and he was one of my mentors, he was like, let's look at the long-term outcomes. But at that time, there was no electronic health record. There was no digital. Like the labs, we couldn't get them in a digital way, right? So what we did, we could get administrative data. You could get, as example, everybody names of the patients and their ICD-9 codes, right? Now, and if you know a little bit about claim data, and you know that administrative code for acute kidney injury is basically code for dialysis requiring AKI. People only code AKI if somebody needs dialysis. Mild, moderate, no. Nobody mentions that.
And it goes under the radar, I'm guessing.
Yeah, so it's not reported in the claims. So sensitivity of ICD-9 codes is at 20-30%. 70% of the cases are never claimed. And so if you want to use rifle, you need creatinine. So what we did, we got 10,000 patients. We knew who they are. We were interested in surgical patients. So well, let's take patients who had surgery and let's see what happened to them. So first we're going to call them and nobody would answer. They said, well, 10,000 patients, we need their creatinines. We couldn't get them digital. So these are all these weird stories that exist in life. So I was, fellow and in a critical care, and then I just became junior faculty, and I wanted to do this project, but who's going to get these creatinines? And then there was a resident in in anesthesia who ended up being on probation for some problems he had, and they didn't know what to do for him, and he was Turkish. Now that's funny, like, and they knew I came from. They're like, "Do you take care of him?" Because, like, I don't know why. Why would they? Because I lived in Turkey, right? Like, funny, right? It's like, cool. I said, "Okay, you mentor him. He's your do something with him." So Sinan, I said, "Sinan, we're gonna go and in 10,000 records, and we're gonna record manually creatinines." So he went in 10,000 records and write down creatinines in Excel sheet. Well, that's a lot of work, right? We don't need to do this anymore, but we did it, right? So we pulled all the data, and we did, and we showed, and that paper was published in Annals of Surgery, right? And in Circulation, showing that AKI affect up to 10 years survival, up to 10 years after surgery, even among the patients who never had kidney disease. So in other words, you look at the patients who had major surgery, they never had kidney problems before, they come to hospital and after surgery develop change in creatinine. Acute dysfunction, acute decline in your filtration function because it's remote in organ dysfunction after surgery. It happens in a lot of patients for different reasons. It can be sepsis, it can be drugs, it can be hypertension during surgery. And these patients, whether or not they recovered back to their baseline, did not do well. Up to 10 years after surgery, their survival was lower compared to patients who never had a kidney problem. First time ever that somebody looked at that, and that was a paradigm change. A lot of study later. Now we understand that it's cardiovascular mortality. We showed that later, that you actually not only are less likely, not only you live shorter after AKI, 10 years after, but you are 2 to 4 times more likely to die from cardiac disease, and 4 to 60 times more likely to develop end-stage renal disease if you have acute dysfunction of the kidney, even if you didn't have any kidney disease before. Part of that is also the progression to chronic kidney disease. Part of that, I believe, is decline in your reserve and perhaps in endothelial health. It's all connected, but that was, that's kind of one of those things, Turkish people say it's called kader, or kismet, it's your destiny, a good one, right? Things come your way because they are meant to happen to you, and the little dots came together. So that's how I became interested, like really in outcomes of surgical in AKI and understanding in surgery what's epidemiology, what are the outcomes, how is it associated with other complications, that we need to change definitions reported in the surgical societies that report only more severe cases. So we showed that the American College of Surgeons has a definition called NSQIP, that definition misses a lot of cases of AKI that are not as severe but are still associated with bad outcomes. That having acute kidney injury after surgery increase your risk for other complications like sepsis, mechanical ventilation, being in intensive care unit for a longer period of time, right? So it really brought radar for AKI, at least in my institution. Like it became like kidney-centric worldview of the perioperative medicine. But if you move beyond where I work, it's one person mission. You teach people. The problem is that there are not many people like me who do both worlds, right? So what you have is a disconnect. The nephrologists, they don't. You see, the kidney, the mild to moderate AKI. So if you think about all cases of acute kidney injury, either after surgery or on the ward or in ICU, in hospital, probably the distribution of the stages, like the mild would be probably in 30 to 40%, and then 20% moderate, and then very severe will be maybe 10% of cases, and maybe dialysis requiring only 5%. So nephrologists see 5 to 10%. They are never called before. People just don't call them for 2 reasons. Either they don't really recognize or they don't think it's important. So, it's one of those interesting things, like and I always ask, so why would you consider, they would say, well, it's just transient, right? Well, the people might be dehydrated, and I said, well, I get dehydrated, but my creatinine doesn't double, right? Like,
sure.
Right? You know, all of us get dehydrated. All of us run. And why is it? It's not. It's the people tend to assign less value to that. I think, and they still don't understand, I think, physiology completely behind that. A lot of that comes also from the biases in nephrology viewpoint of AKI, that the nephrologists themselves were those who are minimizing that, right? So the problem reversibility, like, is it reversible or is it not? If it's reversible, does it mean it's completely benign? I will argue not necessarily, right? We still don't understand that, because now we are seeing by the work done by Dr. Ronco that patients who appear to recover from AKI, if you test their renal reserve, I'll talk about that, they don't have the same. In another word, where it's you are born with 2 kidneys and you have a capacity to increase your work, your filtration, your clearance of the kidney, up to almost 50 to 60% above what you operate usually. So if you operate on 100%, you can maximize to 160% under the stress when you need a lot of protein and water or in a pregnancy. So we have a huge reserve. We call it renal reserve. That's amount of the extra filtration function that exists in human kidneys that can be used. So what we now understand is as you age, that reserve shrinks.
How much does it shrink by?
Well, depends. You know, it depends. Not everybody is the same. Like, and so, you know, the baseline renal function. You know, the creatinine. So basically, you know, vitality of the kidney declines with age, but not everybody declines at the same rate. Just like not everybody ages the same way, right? So I think every organ and the body as a whole is a slow decline. The slope is different in different people, right? So then the certain diseases obviously predispose you for much steeper decline, like hypertension and diabetes. We know that. The most common in American society. So now when you think about it, and aging has a slow decline, but some, you know, in some instances, if you combine comorbidities with aging, then you get a perfect storm, right? Now you have all of these older people who might have some hypertension, no diabetes. They don't even know that. And now they are going all these procedures in hospital. And now under the stress of acute illness, that inability to be resilient comes out in every organ. And the kidney, incredibly susceptible to that.
But unfortunately, it seems that with nephrologists, you're only getting to see it when it comes to that 5% when
yes.
the arrival score, when it's already too late.
Too late, exactly. And then, you know, and the thing is, those who see before, they probably don't know as much, they don't necessarily know what to do. The nephrologists, with, you know, with all of these years of not being there, they don't either know what to do. So there is this gap now. There is this window where we need specialists for that population. So, you know, some kind of crossroad in between acute care doctor, that can be surgeon, internist, intensivist, and specialist for kidney as nephrologist. So, you know, and that area of the research is really something that I think needs to be emphasized more and more.
Take me, so, you know, you gave us a wonderful view from on top of the hill of what the landscape looks like, and definitely a lot of things that are missing. Take us a little deeper into the valley and I guess into the darker part, where if these things are not addressed and nephrologists are not getting a better look earlier on at what AKI is, I mean, how does that put patients more at risk, and what does medicine look like if we don't improve these
So I'll tell you right now, let's take sepsis, because that's a good disease.
That's
we all, you know, it's a right, you know, top poster child, right? So the sepsis, and we have new definition, it's a dysregulated response to infection. Dysregulated immune response to infection that is associated with a remote organ dysfunction. In other words, you're going to get infection like pneumonia, and then suddenly your organs are going to stop to work. Your lungs, your immune system, your kidney, your cardiovascular system, your vasculature, you're going to become hypotensive, blood pressure low, right? So we all focus very much. The cornerstone of the sepsis is now give fluid and antibiotics. We have no therapy for it. All we do is we give fluid and we give antibiotics.
And
we support
fluid resuscitation.
Yeah, there's a whole lot of stuff, right? So we give pressors, we try to maintain, but we don't really have some necessarily thing that can cure sepsis. We have supportive therapy. So organ dysfunction is now core. It's a main part of the sepsis picture. So I'm going to tell you, like, so let's say that we have 100 patients with sepsis. 60 of them will develop acute kidney injury. Okay? Among these 100 patients, currently mortality in hospital is in the range between 16 and 19%. 16 to 19 of those will die overall in hospital, will not make it. So let me guide you through who dies. So among 100 patients with sepsis, 60 will have acute kidney injury. For those patients with acute kidney injury, 1/3 of them will reverse quickly. In the 48 hours, will be able to reverse back. Other 2/3 will have persistent acute kidney injury and will not be able to come back to their baseline. In-hospital deaths occur in half of everybody who has a persistent AKI, and all deaths occur in those patients. So if you die of acute kidney, if you die from sepsis, you will die with acute kidney injury.
Can you repeat that one more time? So half patients who develop this, they have a risk of dying.
Yes. And 1 in 2 patients with sepsis will have AKI, to simplify. One of two with AKI will develop persistent AKI and will not come back to their baseline. And half of those with persistent will die in hospital. And those who make it out, half of them will die within a year.
And at what point during this process are nephrologists actually called in to check? How late is it?
Probably when you need dialysis.
And at that point, it's too late.
Yes. So I think, and I always emphasize that renal recovery, first of all, in the first 48 hours, half of the patients will already develop AKI. So in my opinion, those who can reverse quickly within 48 hours AKI, they have chances to make it. So our first 48 hours goal has to be ability to reverse AKI. So I'll tell you examples. So, and there are things to do. There are ways to do that, right? There are often, I think, sometimes just because something is simple doesn't mean it's not valuable, right?
That's very true. Yeah.
Right. Just because it's cheap doesn't mean it doesn't have a worth, right? But we all want to be heroes, but sometimes we just need to be like, good workers.
It's like Occam's razor, the simplest,
simplistic.
Yeah.
So, in the first 48 hours, most of the acute kidney injury will be combination of the inflammation associated vasodilation, right? And we give fluid, right? In that first 48 hours of the sepsis, we give fluid and we give antibiotics. Often we order tests. We give the antibiotics that can be nephrotoxic, and we give tests that can be nephrotoxic, like contrast, right? So if we have a patient, if you pay attention to this and say, I have a patient with early AKI or high risk for AKI. Well, this is the patient that I need to treat differently than one who doesn't. This is the patient that I don't want to give another insult, right? From insult to injury, because repetitive insults to kidney will lead to persistent injury. These are the patients and that's what we do now at University of Florida. We really do this risk stratification. In other words, what we do right now is all or nothing. Like the medicine, as of now, operates as all or nothing. And why is that? People who do everything or nothing are people who don't really know what to do in between, right? Because, we all understand when you are doing really well and when you're doing really bad. But when you're in a gray zone, we don't know who you are yet. The discrimination in the middle is very difficult. Our tools to discriminate people in the mid-range of risk is very poor, right? So we can say, well, you're doing great, and you're not doing great. Like, between dead and alive, it's we distinguish those. In a gray, not so much.
And it seems that that's one of the big problems right now, that nephrologists don't have appropriate tools for this. It seems that
maybe intensivists. Right now we are in ICU. We are really with intensivists. Nephrology is not even at the stage right now. And I think this is the job of intensivist at this point. So, but this is not built into any guidelines we have right now.
It's either, I think everybody's very good at recognizing AKI, but in terms of the
not necessarily in the beginning. Like we put a lot of value on hypotension and pulmonary function, but in the early stages of AKI, when we have maybe 20, 40, 50% increase or 60% in creatinine, we would just say, well, this is just temporary or transient. Not recognize that this is the time when we need to make sure that this increase does not persist. So first 48 hours, try to reverse AKI if you can. If you cannot, if you are now in persistent AKI, much harder. Now we need to really look into the research that will help us develop therapies for renal recovery. And I'll tell you now, it's not just intensivists. This is now intensivist nephrologists, because I need to say, as of now, that's another problem. Let's say that you have developed persistent AKI. It's more severe and nuanced. You need renal replacement therapy. So some kind of support, because your kidney doesn't filtrate, and you need dialysis of CVVH. Now think about it like a ventilator, right? When you have a lung dysfunction and you need oxygen to be supported by a machine, you're on a mechanical ventilation. But at the end, your goal is always to liberate from ventilator. Nobody thinks about sending you home on ventilator. I mean, very little people end up going to the facilities. However, and I think this is a big problem, right? One of the rare organ dysfunction that you can live with at home is dialysis.
That's true. And I'm
right?
seeing more of these at-home dialysis machines.
And not just that, or you go on a in-center. In other words, the only chronic organ dysfunction that is currently sustainable is a kidney. Because end-stage renal disease, we have a Medicare support, people live on dialysis. Nobody lives on ventilator. People can live 10, 15 years on dialysis, go on transplant, right? So the only organ dysfunction that you can go from acute to chronic and be discharged home is dialysis. Now think about it. So you're going to go from acute disease to chronic. The doctors who take care of you for acute and chronic are the same doctors, right? Right? You see the problem? Like, not necessarily with a bad intention, but the most nephrologists are focused on chronic disease, how they manage chronic dialysis patients. That's not the same, right? I always say the number one goal for management of acute kidney disease that requires dialysis in hospital because of AKI should be to get liberated from the dialysis. But that's not what we think, and that's not how we practice.
Yeah, and I want to bring something up. You mentioned, you've been very popular on Twitter. A lot of your slides have been very, very much retweeted and tweeted about. And you had one about cognitive dissonance and cognitive biases that exist. And one was the Semmelweis bias, which, for our listeners who don't know, Semmelweis was a physician who introduced washing hands early on in surgery, and he was rejected by all his peers, and they thought that he was crazy, and this wasn't accepted until 20 years later. The idea of this bias that you had mentioned was to reject new evidence that contradicts an established paradigm. So do you see that happening right now, that there's new evidence that's coming out, but a lot of the physicians who are out there, they're holding on to the way that they used to be trained and the paradigms that they're used to?
Yeah, just think about it. The rifle was published in 2004. Mm-hmm. We are here 14 years later and people still don't use it.
And why is that, you think?
Rifle, Aiken, KDIGO, consensus guidelines by societies, nephrology, published, exist. Still there are nephrologists who don't use it. Nephrologists. I go on rounds because again, it's really hard to change beliefs. And all of this epidemiologic evidence that mild to moderate AKI, even if it's transient, is associated with bad outcomes, that persistent is associated. And when you go, and here's an interesting thing, like alerts, electronic alerts. As of now, the problem, there are a couple of problems there. The first one is to use guidelines, you need to, one value of creatinine is not enough, right? You need to use the consensus guidelines define AKI based on change in creatinine. So you really need to understand baseline renal function. So you need to use a little bit of brain. You need to put some work there, right? You need to go and think about, well, what is your baseline renal function? What do I think is your kidney health before? You need to think that, right? Okay, and you need to maybe look at the records before. A lot of people they don't know about that. When you go to doctor, nobody tells you, oh, your kidney health is this. No, they're going to say, your heart looks good, right? Like, whoever tells you how your kidneys look like? Never. I mean, like, I can't even it's all about heart, unfortunately. We are so focused on certain organs. And there's a cultural fixation on heart, on cancer, on brain, right?
But there's hundreds of thousands of people that die from AKI, and even me, having been through medical school, I was surprised to learn about this. Why is it not more public? Why are people not aware?
Well, both patients and doctors don't know. So, the consensus guidelines exist. You need to understand baseline renal function, then you look at the change of creatinine, and then stage people, and that's hard. So right now we are working, and we have developed something called electronic phenotype for acute kidney injury, where instead of doing that, you will autonomously in electronic health record stage AKI. And Dr. Kellum in Pittsburgh already has that alert, and in his institution they saw, just by the fact that it's reported there were better outcomes. There was a slight decrease in AKI. But Dr. Wilson in Yale did a study where they randomized doctors to send them alert on their pager saying, hey, your patient in bed 2 has AKI. And one group got alerts, one didn't. And then they look what happened. Guess what happened? Nothing. Because doctors who got alerts and doctors who didn't get alerts did the same thing.
I was going to say,
there was no difference. They didn't follow guidelines. When you ask them, do you follow KDIGO guidelines? Of course we follow guidelines. When you look, they don't follow guidelines.
But the actions didn't map to
Of course, knowing is not acting. So, and it's a very difficult problem. It's not just kidney, it's many other things. But here's another thing. So you're going to have, when we look at the documentation, right? So if you look at all cases of acute kidney injury, let's say you have 100 patients with AKI. Of those 100 patients with AKI, only 30 of them, like 7 out of 8, will not have mentioning of AKI in their dishes. It will never be mentioned in their notes. Never. So they're going to leave without ever knowing that they have AKI. As a matter of fact, like stage 3, that means tripling. That if you have stage 3 AKI, that means that you at some point lost 80% of your kidney function. 80%. Even among those patients, half of them never have a mentioned AKI in their discharge summary.
And it's because it hasn't led to dialysis. Is that the
This
reason?
is the doctors, though, that's, they didn't need dialysis, so that's okay.
So as long as they don't need dialysis, it's fine.
Yeah.
But they're going to later on because they've gotten to such
exactly.
a bad point. And there's nothing to do to
So this is ridiculous, right? And it's not going to be reported in a national database because it's not coded.
And so if it's not reported, there's no problem.
There's no problem, right?
And it continues.
Exactly. And then you're going to leave. The data showed 80% of patients who leave with AKI never get creatinine again measured. They go to doctor. They didn't even know they had an AKI. Every episode of AKI put you at the risk for the next episode. So next time you come, you're more likely. So you can go and see these patients coming up and down and slowly developing chronic kidney disease or dying or having heart disease, because most of the time you will not end up on dialysis. You're just going to end up dying of heart disease. So it's a problem. It's an invisible disease that for some reason we have a problem assigning value to, and we don't have a real owner, right? And we don't really have report as any measure of performance, right? So very interesting.
it's fascinating, but it's also very scary.
It is.
So we went very deep in the valley of what this can turn out. Now, I do want to talk a little bit about some of the great work that you and your team have been doing, but also if you can kind of take us up the hill and give us a sort of a better look, like if these things are addressed and they improve in terms of how they're being treated and the way that we're looking at AKI, what could the future look like? A brighter future than what it is right now.
So first, in my opinion, first we need to, in general, stop doing everything or nothing.
No more acute or chronic.
No, not just like we'll do everything. Everybody gets everything, or nobody gets anything, right? You know, like
the gray has to be.
Yes. Yeah. In other words, when you come with sepsis, you don't just get everything the same. Not everybody gets the same therapy. It makes no sense.
Because not everybody's the same.
Right. Because you will over-treat some people and under-treat others, right? Mm-hmm. It's total logically. Because not...
You don't have to go to med school, though.
Right, yeah. So that means you're going to... Because over-treating is as bad as under-treating. Waste economic, because we will bankrupt, first of all. Second, we harm people by doing too much, clearly. But then on the other hand, we harm people when we don't do right thing, what they need, right? So rather than doing too much or too little, we'll just do the right amount of things for you. So that's number one. Number two, we need to utilize what we know, right? So how do you use the knowledge that you already have, but you just don't know how to apply it? Because having knowledge and applying knowledge are two different things, right?
Just like in the
I know that I shouldn't eat too much and I should exercise, but do I do that? No. To the fault of my self-harm, most of the humans hurt themselves, right? I mean, it's well known. The will, the power, the discipline, nada. There is nothing like that, right? So, even as a doctor, you want to do all of these things, but at the end you're just human, right? So you need help. You need just like you live in, and I think so first of all, we collect a lot of information on patients. It's there. With the digital electronic records, information is there, but it's absolutely ridiculously scattered and it's overwhelming. Like if you ever use electronic health records, there is nothing appealing in them. Digitalization is amazing, but as of now, doctor hates it. Because as of now, it's not usable to doctors in a way that would help them or augment or facilitate because, it's just a big spreadsheet in front of you.
You're just inputting data all day.
That's what you are. You are like unpaid data entry person. All of us, nurses, doctors, that's what we do, right? I mean, totally. It's unfriendly. It's based on the very old programs. We all know that. You're in front of the spreadsheet and, and every time on the rounds, we look. People don't even look at that. I still on my rounds have people come with a paper and they are like writing. I said, why do you have a paper? Look, here's the data. Why do you need a paper? Just look at the screen, please. Stop reading from the paper. We are still reductionists because we want to reduce, because that's how we operate human. It's too complex. We have to reduce information. In some way we understand. And then they read, you read each, you said brain, lungs, and you describe parameters. And I said, okay, well, just answer one simple question. Is this patient better, worse, or the same as yesterday? Well, you can't answer that question.
So you only can answer if they're really bad or good?
Even that.
Because why do you think that's?
Because it's a really hard question, right? That aggregation, the aggregation and putting things in patterns in a real time, in a kind of temporal way, it's a very hard thing, especially in intensive care unit. So, maybe, as I say, when somebody is really doing well, we can say. I think for the most of the people who are stable, and I always tell them, if you think they are the same as yesterday, that means they are worse. You just don't understand it yet. Because in ICU, you only can get better. If you're not getting better, you are getting worse. You're just not catching up the moment when you go down the rabbit hole. Right, so that is really important. And using that information, electronic health records, to augment your decision making in ICU is number one priority right now. Because as of now, we can easily base, as example, on AKI, and that's the kind of what we do. We said, well, okay, we have two things. We have so many studies that we know what constitutes clinical risk for AKI. I mean, the KDIGO published that says it's susceptibility and exposure. It's a combination of your previous kidney health and exposure, acute exposure. In other words, how healthy you are. You are an older guy who had diabetes, hypertension, so your kidney health is not very good. If you go in now and get sepsis and hypertension, you're not going to do well. You are high risk. You have potential for high risk, right? But you could be a young guy, but then you develop horrible septic shock, and you get 3 bad nephrotoxic drugs, you get hammered, but you can also develop AKI, although your health was good, So it's a really big exposure, or is a combination of susceptibility, and it's less severe exposure. But still, not everybody develops AKI. But now we have a biomarker too. Now we have something that can biologically tell us. So we combine two. So in other words, if you use biomarker that is not perfect, because it's not perfect, the biological biomarkers are not perfect yet, and I don't think they will ever be, just one marker, then you need to combine them, right? Because if I say, well, not everybody needs $50 or $100 test. Not everybody needs whole genome. Maybe one day, if it's $1, we will have it. But as of now, if something costs $100 test, and I have 100 patients, if I can test only 50 and got more information than testing 100, why would I test 100, right? So that's what we do. We say, well, we're going to use electronic health records to quantify your clinical risk. So if you are low risk, if you have no susceptibility and you had no exposure, why would I test you? You are doing great. Please leave him alone, right? I mean, I don't need to convince myself that you're doing good. But if you have a high clinical risk, some of you will develop AKI, now I use biomarker. And if the biomarker is negative, then I will still do nothing, because it tells me that you had a clinical risk, but biologically you are doing okay. And then I'm ending up with only 25 patients on my initial 100 that really need my focused attention.
And those are the ones that are most complicated that need the focus attention.
I need to focus on kidney. The kidney becomes my focus. Now I'm going to say, hey, you're going to get creatinine every 12 hours. I'm going to measure urine every hour. You need Foley. Not other 75, but you need Foley. You need urinary output hourly. You need ultrasound to look fluid. You need more monitoring. You will not get vancomycin. You're going to get more expensive antibiotic that doesn't hurt kidney, because if I give you nephrotoxic drug, you're going to end up with the dialysis that costs thousands of dollars, and you're going to be dead. So let's save some money on what matters, not on one drug. We need to see you have that kind of orthogonal view, right? You need to defocus from the short term to look in the future, long term. Because you are not helping person to leave the hospital. You are helping person to have a good life year from now. Right? So that is the problem. The healthcare is fragmented, right? So you have a doctor who sees 12 hours in surgery only. Then he gives you to doctor who sees 7 days in ICU. And then you exit ICU, you have doctor who see until you leave hospital. And then you have but nobody's seeing you a year from now. As I say, we should all look at you. How can I make you from year to now living fully functional life at the same quality you had before you came to this hospital, right? That is the problem. We need that view. And for that view, we need to change paradigm of fragmented care that is not guided, that is not optimized.
This sounds like, and I know that you have a lot of experiences with this with regards to your deep SOFA algorithm, that this, it seems like it's trending more towards like predictive health. To be able to predict how a patient is, how a person is even, forget patient, 1 year, 2 years, 3 years from now. And you mentioned that focusing on the short term in order to have a long-term view. So in the short term, you mentioned with these patients who, let's say that 25% you focus on who have very bad kidney injury, right? You said increase urine output, more monitoring, etc. So you have an influx of data. Can you talk a little bit about the value of using technology to solve for that influx of data? So that way, I think physicians and nurses have this reaction to more data because They have to manually manage it.
Right, exactly. So the problem with data, big data in medicine as of now, is that it's a big problem.
Big data is a big problem.
In healthcare, everybody wants to be there, but it's not as simple, right? It's not as simple as shopping on internet.
That's a very, very valid point, yes.
Yes, because, the probability of harm, is higher. The complexity of the problem is immense. The dirtiness of the data is incredible. So, and the fragmentation of the data is even more ridiculous. So, I know a lot of people think about this, and I just live it every day. I also have I'm also board certified in medical informatics, and my whole research was in informatics and in big data in healthcare. But I started when my hands go dirty, right? So a lot of people don't understand this. Like, a lot of people say, oh, now we have all of this data, we're going to do all of these beautiful things. Well, first of all, stop there. Okay. So think about data. Where is it coming from, right? So how is data generated in medicine? So where does EHR data comes from, right? So it comes actually still from different places, right? So let's say just focus on the data that comes from monitors. In ICU, every patient is monitored. Vital signs. That's just fine. Blood pressure, your heart rate, oxygen levels. Just take those three. So they are continuously monitored on the monitors. Those monitors record data with a very high frequency, 60 hertz, 100 hertz. They can give you like waveforms, right? That data is de-identified. It doesn't have your name. It's just the numbers. The data comes from that monitor in the format that is protected by company, right? You can get it in HL7 format, as the universal format, but it's too much of the data to come to the electronic health records. So electronic health records takes only some of that data. Let's say it extracts from 60 hertz to 1. So you just get 1 per minute. Let's say that you have 100 per minute data points, you get 1 per minute, but still good. You are in ICU now, and when you're at the bedside, you see waveform. Now the data comes in electronic health records, but it has no name. And this is the most ridiculous thing I've ever heard. So now, how does it get associated with you? How do I know now that's your data? Well, the way how it works is, at least in this system, and I'm not going to name it, is that the nurse at the bedside gets a spreadsheet, and she associates you with the data point, and she picks up one data point and validates it. And the data in electronic health comes every 15 minutes, not every minute. So you archive every 15 minutes. And you use manual validation by the bedside nurse. Is that ridiculous or what, right?
It's taking an old problem and just putting a new hat on it.
Like, I mean, how hard is it like to have a tag on the data and associate automatically, right? It's not. But we have too many interests floating. And I said, like, healthcare market is absolutely flooded with monopoly. Like I said, like, if certain devices that we use on a market, free market, they would never survive. Never. Like, we still live in a room that has 1 million of wires, with the beds that are like 100 pounds heavy, you can't move them. When you want to go at a patient bed, behind their bed, you need to move these beds, move the wire. It's like ridiculous. Like, it's like, who wants to be in this room, right? But the market is not open. The market is not competitive market.
Do you see that changing now with companies like Apple and Google and Amazon and all these tech companies coming into medicine? Is that going to help? Is it going to complicate things? Or
I don't know. I don't know whether they will really come in. It's not so simple, right?
No.
And, I think it will happen. I think that and I'm not sure that, the data as of now is not going to leave easily your institution. The ownership of the data, the people who generate the data, doctors, hospitals, patients, who the data belong to, do they want to send it in some cloud? I'm not sure, right? I'm not sure that people understand that data is very valuable. So the way how I really, I have a vision. I have a vision of, I call that intelligent healthcare. I think what we learn a lot about personalized healthcare. We understand that there's a biological determinants of care, like we know about genome, about proteome, metabolome. We learn about that. We now learn about precision medicine. We can predict models. But I think the intelligent medicine is about delivery of the care. Mm-hmm. How do you deliver intelligently care? Using technology to help you deliver. So, I call it augmented reality of healthcare, augmented healthcare.
Essentially augmenting the skills of physicians.
Everything. You're augmenting experience.
Tell us a little bit. I want to touch on it, but some of your work came out, and it was very exciting. Can you tell us a little bit about Deep SOFA and what does SOFA stand for?
Right. So that's one of our projects that we are trying to develop, to use machine learning and to develop algorithms that can use all of this data and predict probabilities of certain events. SOFA stands for Sequential Organ Failure Assessment Score, that is used in sepsis now to quantify organ dysfunction using 13 variables. It's a very reductionist approach,
As you mentioned,
1 to 4, you're gonna say you're doing 1 good, 4 bad, but it simplifies things.
And it's manually done.
It was meant to be manual. It's not done because it's manual. Nobody on my rounds know what the SOFA is. We have to pull Wikipedia all the time, although it's in their definition, right? So that's the thing. Like, all of that knowledge exists, but it's not used. So we wanted to use the same information in autonomous fashion, so the computer will calculate probability, display to you, and also be interpretable. In another word, it will point to you in a time where you need to pay attention to events. That something is happening there. And that's why the mortalities go up. So you go and you do your triage. Then you use your skills to understand what's going on. Your exam, your visual, because as of now, there's your eyes, your feelings, your experience is unreplaceable by computer. The computer is not there. You are, right? That's what you have. One day maybe a computer will have that, but as of now, human has that, and the computer does. So that's what we are trying to do, and we want to deliver that in the room, and we want to deliver that to you, doctor. We want to deliver that to your nurse. We want to deliver that to your caregiver and to you as a patient. We want you to see that. We want to see your trajectory. We want to see when you're green or yellow or red. Because, the patient in a current medicine is a victim. Right? That's how we see. The medicine see human as a victim of the disease. But I want to see you as a protagonist. This is your story. No story ends well if you are a victim.
Very true.
Right?
Very true.
Only those who take action and become protagonists and directors of their destiny do well. And we have never tapped in that potential of a human healing that exists in us, because we heal. Without any doctors, we can heal. And we absolutely don't understand much about it. I personally think. So the power of healing that exists in your organism, in your cells, we need to tap into that. And I think number one thing is that make patient protagonists in that story. In that movie is about you. He becomes the center. He knows he cannot live in a black box. That environment has to become enlightening, telling you, questioning everything that is done to you, and working together with the doctors to get better. And so that's kind of like, and I think that the space that we are in is like indifferent. I mean, it's dehumanized. It's not human-centered. It's alienating. That needs to change, right? So and maybe one day your home will be your room. Maybe you don't even need to come to hospital. I don't know. Or can resemble. So, I just kind of I like to think about the future, how we can change this whole paradigm of the healing and medicine one day.
Do you feel that that predictive technologies now, like take Deep Sofa, for example, when better technologies come out, you help the physicians and nurses be their own protagonists, and if they can be protagonists in their own stories, they can focus more on helping the patient become a protagonist in their story rather than a victim.
Absolutely. So, as example, nurses are absolutely so most of the time now, healthcare providers are data entry people. Most of them, there are studies showing that 80% of their time nurses are spent charting.
Which is not what people went to medical
Even
school
in
for.
ICU.
Even in ICU.
80% of the time, ICU nurses do charting, 20% direct patient care. So that means that 20% of the time you are not observed in a hospital, in intensive care unit. You are unobserved, you alone. And that's another project we are working currently, that not just intelligence AI, you need pervasive sensing. You need environment that senses you.
24 hours.
24/7. The room is a part of the care delivery. The camera, we have a very simple system, like where we use camera, the new camera, like and like kinetics cameras, where
on the patient.
On the patient with accelerometer, sensor of the light and noise. And I can tell you, right, and the paper is also in the scientific reports right now under review, that the low noise level in the ICU, the white noise level, is 3 times above WHO recommendation for the healthy noise level.
Really?
The light level is absolute, there is no pattern. Like in circadian rhythm, night and day, it's too dim in the day and it's too light in the night. The patients are constantly interrupted in the night. That's why we have a delirium in ICU. That's why people go crazy in hospital.
You can't sleep.
Of course.
So
how easy would it be to have a feedback loop that measures light levels and it's automatically adjusts them?
We have it on our computer.
Right? Or the noise level. We also use VR in our interventional trial. How easy it is to give patients VR. They love it. Just to relax when they are stressed. So these little things that we can use can make huge impact. It's not all about, this is a drug-centric, right, procedure-centric healing. It doesn't tap in your self-regenerative capacity. It doesn't tap in your mind, in your spirituality. None of these.
And all things that have shown over time to be
right.
a huge help.
Of course. And guess what? We just like drugs or procedures because it was consumer-centered healthcare.
And it seems like there's this theme that you keep mentioning and it keeps popping up where it's either acute or chronic, good or bad. And it seems like that the old way of medicine, maybe the old way of life, is black and white, and that where we really should be living and understanding is in this gray area that you're speaking
continuum.
about. The continuum.
The health is not acute and chronic. It's only one health.
Right.
And you need to see it as a continuum.
That makes a lot of sense. And there's
right.
even an old quote that says that the person who looks at another being and says that they are either a god or a monster forgets that night and day is still one. And it seems that this is the same way with medicine and patients, that it's a continuum.
Exactly.
So you see that? Do you see the hospital or the future being these? It seems like an intelligent room or a smart room that is sensing.
Yes, and it never stops. It exists in your home and exists after you leave.
Because it's a continuum.
It's a continuum of health. We will be becoming. I think we will become smarter, understanding the changes before, then acutely more intense, and then again when we leave. Right? There is no reason that we stop watching. How is our, blood pressure performing? How is our heart rate? Recovery period is very important, right? Patients, even in the hospital, go from in ICU being watched, one nurse, one patient. Just get a little better. We send him to the floor where one nurse watch 8 patients, and some people don't get seen by 4 hours. Well, better be at home. Sometimes it's even better to be home. So, that kind of gap we don't have a good transitions, and we don't have this big view from above. And I think that will require like restructuring our understanding, the fragmentation of the medical care on every level, on a data level, on a monitoring level, on a health delivery level, on the workforce level. The fragmentation is the problem.
Absolutely, and it seems, this concept that you mentioned about making the patient, instead of a victim, to see themselves as a protagonist in the story, I think is a very powerful narrative. Do you see that, with a lot of these consumer tech companies, they're coming up with wearables and stuff, that if they do it the right way, they can educate the population to be that protagonist and take more charge of their health?
Absolutely.
We've seen it with the internet and WebMD, that patients are more educated when they go see their doctor. How do we continue to close that loop so it becomes more of a continuum?
That's a great question. I think it's really important. I think we need to open the box, the black box of hospital care, right? And continue to educate patients, medicine is a privilege. Being a doctor is a privilege. And it's a challenging profession, no question about that. And I think that, with the regular, we try to control quality by punishing errors, not by fixing them, right? Impose more and more, like if you don't perform this, you're going to do this. If you don't perform, like it's a punitive. And I'm not sure that's the best way to do that, right? I think empowering from inside, both doctors and patients, is probably a better way to do that. And I don't know, it's an interesting concept. I'm not by no means healthcare reform specialist or anything, but I live in it. I see how hard it is for both doctors and patients. And I always tell my patients, be loud, stand for yourself, speak for yourself. Patients have power, but they often don't use it, because they are also in this kind of conservative environment where whatever doctor says, that's what it is, right? And that's nice. It's nice to trust, but I don't want to. I think that kind of paternalistic way is something that we need to step away from.
They have to be the protagonist.
Exactly.
They have to stand on their own 2 feet and
yes.
see. Maybe they need to look at the doctors and nurses in the hospital as tools rather than the heroes and heroines to help.
Exactly.
Them. That's a very interesting concept. So
partners. They are all partners. That's how I see that. Because, we see that even in a gender distribution, like in a medicine, like that kind of old way of paternalistic medicine, it's very hard to abandon, but slowly with the influx of the women and, people, necessarily carry that image, of male culture. It's changing.
They say that the hand that erases is the only hand that can write the truth. So what does medicine have to look in its current history and current culture to erase so we can start writing the truth?
Oh, that's a great question, right? I think that, I gotta think about it.
No, that's okay.
Yeah. I think it first needs to admit vulnerability, right? I mean, it has to admit that sometimes there is nothing to be done, and it's okay to say that. I think it also has to admit that it is not mechanistic delivery of drugs or procedure. It is healing. It is about healing. It's about human connection, right? Most of the time, we are all going to die as of now. Maybe we'll live 200 years, 300 years. I don't think we will be immortal, but, we will die. So I think the medicine needs to embrace death first in this society. And also embrace that often, instead of preparing for death, we are just trying to run away from that. And we hurt each other even more, right? You know? So we don't optimize dying at all, as of now. At all. And I don't think we can optimize healing if we don't optimize dying. They are all connected, right?
It's all a continuum.
It's a continuum. It's a life, right? So I also think that we, rather than being reactive, that we only react to events, we become proactive. So we start thinking about our health when we get born, right? And we very much invest in a health span concept, starting with the young people, providing them, because that's when we can, longevity will start when you are healthy, not when you're sick. Then you're all in reactive mode. But there is no money to be made in the current, in the current concept of the healthcare. There is no money to be made in preventive medicine. Probably people say, well, if you prevent everything, then there will be no medicine. But who cares? It's not about money at some point. I think that is another hard concept, right?
Well, do you think it's possible where maybe the new paradigm is, instead of treating the disease, it's helping people to optimize this continuum of life and health, perhaps?
Yes, but and I think that the question comes like, is the health privilege? Or is it a right? Yeah, it comes all the time. Having a healthy life, I believe it's a right, but it's also a responsibility. Because nobody's going to give it to you. You're going to work for that yourself.
And I guess like a big theme about this is, as you mentioned before, about being the protagonist, is
yes.
taking responsibility for it.
Yes, and the doctors and we need to educate patients about that even more and start very young.
And maybe part of the education is, it seems, at least from what you were telling me, it's empowerment, right?
Exactly. And I think that's where technology can play a huge role. I think people more and more now understand that, like exercise and all the self-monitoring, the wearables, the diets, the whole plant-based diets, like the things are starting to vibrate in the mind, and it's a different generation, and it's fantastic, and this generation needs to step up and kind of look for new paradigms. It's not going to be your dad and your mom's, and it shouldn't be. They need to ask. We need to ask more. That's a lot.
Well, I have to say it was an honor and a privilege to speak
Thank
to you.
you.
It was very, very insightful, and I think you gave us all a lot to think about. So, Doctor, thank you so much. Now, real quick, I know that people are going to ask, so I have to ask, how can people best, find you? I believe you have a Twitter handle. How can people, follow you online?
Yeah, you can follow me on Twitter, and I constantly want to write more. And like I have this blog called Kidney Love.
Kidney Love?
Kidney Love.
How do we find it?
I don't know. It's still not very active, but I'll figure it out, and I'll let you know. And because I think about these things a lot, right? I mean, even on a personal level, right? I'm really interested in that, and there are many fascinating things coming our way. What is kind of almost amazing to me is that not a lot of doctors are interested in health and wellness, and all these new crazy ideas that are over somewhere there, and they're amazing, right? So there are some amazing ideas among people who are not doctors, and there are good ideas that we need to put those two worlds together, and that's what I like to do. And I also like to give a wisdom prose about life and love.
We love those kind of things. What's your Twitter handle? So
Azra Bihorac.
And can you spell that for us?
AZRA BIHORAC.
Perfect. And we'll put that in the show notes. Doctor, thank you so much
Thank
for
you.
joining.
Thanks. I hope it was okay.